Doctors and healthcare professionals who prescribe medications play a key role in the responsible and effective use of opioids. Joining us now to talk about how opioid prescribing practices are changing is State Medical Officer Dr. Greg Holzman. And thanks for being here this morning, Dr. Holzman.
Thank you.
So let's talk about how the opioid crisis has changed over the years.
Yeah, I think that's really important because it changes kind of the idea of how we prescribe. So as earlier folks have talked about, the prescription rates went up quite a bit 20 years ago, and we saw a huge increase of the overall prescriptions for a multitude of reasons as discussed prior. Now we're dealing with the consequences of that. And so when we start to look at appropriate prescribing, I think a lot of times we as providers, or even in looking at things as a population, break the groups up into different areas. We have what we call our legacy patients. Our legacy patients are people that might be on chronic opioids, did exactly what their provider told them to do. Mm-hmm. The doses were increased, and they continued to have pain, but they had, things, and now they have an addiction or at least a strong tolerance to that high dose. And all of a sudden people are not prescribing it anymore. So how do you deal with those patients and deal with it humanely and help them wean down appropriately, or if it's a point where they have an addiction, get them into an addiction specialist that can work with it, understand all the aspects behind it. Then we have what we call the naive patients, who, that doesn't necessarily mean they haven't been on opioids before. They might have had it after a surgery or something. They might have tried some before, but they haven't used in the last, people use arbitrary time, 45 days, 90 days. Those are ones where the CDC guidelines are, I think, fantastic as far as kind of really thinking through how you would prescribe to them. So we don't continue to be in the problem that we're in. We don't have a whole new generation of people that are on high dose opioids and have high risk of overdose and other complications. So we're kind of looking at it in a twofold way.
Okay, and so now today, knowing that the crisis that we're in, are there different ways we should be looking at this opioid crisis?
Well, I think, there's, as a population, again, I really talk about three major things that people try to do, and that's just to make it more simplistic. But we want to prevent the problem. So that goes into appropriate opioid prescribing, education to the public, to providers, to kids as they're growing up, and just talking about opioids or drug use in general. We want to help those people that are addicted, and so those are treatments. And in the United States in general, our treatment system is cut-mealed, and it has its own issues, and it's definitely, we don't have enough providers. So how do we use this in the best way to get those people that need treatment to get care and compassionate care treatment? And the last thing I would say is naloxone. Naloxone is a drug that reverses an opioid overdose. And we're trying to get it out into the public a lot more, or first responders, police officers, others that might be around somebody who has an opioid use disorder or is using opioids, or even might be on high-dose opioids because of cancer pain or something of that sort. But when you give the naloxone, it reverses the effect of the opioids and can prevent the person from dying. You still need to get them to the hospital right away, because that will wear off and they'll go back in. Plus, when you give the naloxone, people go from the point that they were usually obtunded or sleeping to quick withdrawals. So they're in misery when they get the naloxone. It's not a comfortable feeling for them, but it can save lives.
What is a prescription drug monitoring program, and what role is that playing in the opioid prescribing?
So prescription drug monitoring is a very useful tool. It's different a little bit in each state, but I think almost all states have it. The only one that didn't have it was Missouri, and I think they're almost there. So, and many of them are talking across states, but we can look in those people that have access to it. You can only should be looking at your patients or reasons that you have to be there, but can see what a patient is taking as far as in the areas of opioids, and some of the other ones have more information of other drugs that you might be concerned about, some of the sedatives or other things. And that allows better patient care, because I think a provider can look in it and try to prevent drug-drug interactions or have real concerns about it. and think through that. It also allows a provider to see if somebody might be doctor shopping, as we say, going from different provider and actually have a substance use problem, and how do we deal with that, or if they're going to different pharmacies and stuff of that. So it's a wonderful tool in a lot of different levels and used in different ways in different states to help us give better care for the individual patient and for the population at whole.
Okay. I've heard you talk about disease of despair. What do you mean by that?
Yeah, and I think that's real important to do, because people talk about substance use disorder in general. And I'll still say, our number one problem in Montana and probably in most states is alcohol. Still is. Opioids has been a major problem, and it's shown the quickest deaths, where we've seen death rates go from, in 2010, 21,000 people died from opioids alone. By 2016, it was 42,000. The diseases of despair are, why are people getting into this? And we see that there's a lot of associations. We also in Montana and many of the mountain states have very high suicide rates. That could be very much associated with this. Opioid use disorder, alcoholism. People have despairs underlining maybe trauma that has happened, adverse childhood events, different things that they went to these drugs knowingly, or happened because a doc gave it to them, and then they've had this feeling of feeling a little bit better. To find their happiness. And so it's saying we need to look at those underlying issues and start to deal with the diseases of despair that might be causing these problems. And it's just moving the stream much further up. And that could be from childhood. There's a new thing called the good behavior game that's happening in a lot of schools that's teaching kids better resilience and dealing with it. It can talk about better connectivity within our communities. We all talk about, what has the electronic, revolution had, and there's been huge benefits to it. But the other questions are people getting the chance just to talk and be human together? And what things can we do in the communities to start addressing these issues, and not just think that person, that's a drug user. There's a really good person behind all that, and how do we get to them and help them with all their struggling?
Okay, great. Thank you so much. We're out of time, so we're going to stop there, but thanks so much for being here and for all that great information.
Thank you.
And I would like to again thank Dr. Abentroth and Lisa Sather for sharing their expertise with us this morning as well. And that's all the time we have for today. We hope you'll come back next week. Until then, stay fit, stay well, and stay healthy for life with Healthy Living for Life. Have a great week, everybody.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the YouTube icon. Special thanks to Fire Tower Coffee House and Roasters. Production facilities provided by Video Express Productions.